Hello, everyone. I'm Sophie Mitra, Professor of Economics and Co-Director of the Disability Studies Program at Fordham. I will be introducing this lecture, our moderator and our speaker. So before I start, a couple of housekeeping notes. I would really appreciate it if you could leave your laptops and phones aside for an hour or so. In terms of access, we have reserved a few seats at the front for folks who might benefit from viewing or hearing the talk from close. So if it does help you, please feel free to move forward. We also have some access copies of the slides in 18-point font. So if you'd benefit from having these hard copies, please let us know, raise your hand, and we'll bring them to you. So another note, if you are attending this lecture as part of your coursework and need an attendance ticket, we will be handing these out towards the end of the event at about 7:45 from the table that is outside. There'll be some PhD students who will be handing over attendance tickets. So welcome to the inaugural Fordham Distinguished Lecture in Economics. Welcome on behalf of the Economics Department and the Climate Committee who organized this talk. Welcome also from the Chief Diversity Officer, the Faculty of Arts and Science Deans, the Fordham Faculty Working Group on Disability, and the Economic Society. These are the co-sponsors of the talk, and we're extremely grateful for their support for this event. So women and members of minority groups have been underrepresented in economics among students, faculty, and professionals. For example, in 2016, only 24% of tenured and tenure-track faculty in economics were women, and 6% of tenured and tenure-track faculty were identified as African Americans or Hispanics. So the situation has barely improved over the years. So in this context, last year, the Economics Department at Fordham established a climate committee aimed at examining issues to enhance diversity and inclusion in economics at Fordham. Our focus in this committee is to develop initiatives and resources that may expand and diversify the student population that considers studying economics. So this lecture is part of these new initiatives. Our main purpose with this lecture is to expose students to a topic and a scholar that they might not typically study in the intro courses in economics, and thus broaden the sources and the scholars that they are learning from. So let me now introduce our distinguished moderator and speaker for tonight's lecture. Our moderator is Dr. Subha Mani. Many of you already know her and love her. Dr. Mani is an associate professor of economics and a research associate of the Center for International Policy Studies at Fordham. Her areas of specialization are development, program evaluation, field experiments, applied econometrics, applied micro, health, and education. Subha's main area of interest is in understanding the causes and pathways through which human capital, so health, education, training, language training, can be accumulated for young children and adults. She has examined these issues in using data for Indonesia, India, Ethiopia, Peru, and Vietnam. Subha has worked on numerous evaluation studies and undertaken extensive primary data collection in India. Her scholarly work has received external funding and has been published in many leading journals. Our speaker is Dr. Janet Curry. Janet Curry is the Henry Putnam Professor of Economics and Public Affairs at Princeton University and the co-director of Princeton's Center for Health and Well-Being. She also co-directs the program on families and children at the National Bureau of Economics Research. Dr. Curry is a scholar whose work spans labor, public, and health economics. She has made fundamental contributions in many areas and on a wide range of issues. So just to give you a few examples, the effects of unemployment on fertility, trends and drivers of mortality inequality, the impact of blood lead on children's future test scores, the impact of contaminated drinking water on infant health, the role of physician education in addressing the opioid epidemic, and many, many more. Dr. Curry has also helped advance the status of women in the economics profession. Curry has been committed to gender equity in economics through a variety of endeavors as a scholar, mentor, and department chair, but also in her service in the American Economics Association. She was co-principal investigator on the initial National Science Foundation grant that funded the CEMENT mentoring workshop. So the workshop is aimed to mentor female faculty in tenure-track positions at PhD granting economics departments in the US. So several professors in this room, including myself, have benefited from this workshop. So I attended more than 10 years ago when I was tenure-track with 3 young children, and I received support and tips on a variety of issues, from how to get published, how to get funding, to how to stop feeling guilty for traveling without my children. My experience aside, the workshop has been shown to result in significant improvements in top-tier publications and in the receipt of federal grants. Dr. Curry's current research focuses on socioeconomic differences in health and access to healthcare, environmental threats to health, and the important role of mental health. Dr. Curry is a pioneer in the economic analysis of child development, and this lecture will give you a taste of her illuminating research. Please join me in welcoming Dr. Janet Curry to Fordham.
So, thank you very much all for being here. I'm honored to be invited. I'm also very echoey. Yeah, I look forward to hearing your questions at the end of the lecture. So I'm going to talk about child health as a form of human capital. Often people ask me, what are you doing as an economist studying child health? And I'm going to try and make the case for you that this is actually a really important form of capital. Okay, so what is capital anyway? If you just look it up in the dictionary, here are 2 definitions. One is wealth in the form of money or other assets owned by a person or organization, or available for a purpose, such as starting a company or investing. A second definition is simpler, that it's a valuable resource of a particular kind. So human capital then is a particular form of wealth that's embodied in people. And historically, economists have studied this, but they've been interested in education as a form of human capital. So from an economic point of view, what you all are doing here is investing in your own human capital, and you expect to have some payoff for that down the line in the form of higher wages, for example. Child health, to the extent that it was studied as something that affected people's human capital by affecting their education. So the kind of story that you would hear is, well, if a child is sick, then they won't be able to go to school, and that will affect their education, and then that will affect their earnings down the line. But increasingly, child health has been recognized as something that's important for its own right, not only through any effects that it might happen to have on people's education. So this research starts really right at the beginning of life. There's a lot of work being done looking at conditions while people are in utero, and then following them up to see what effect different things that happened basically to their mother while they were in utero have on their future life. So the kind of shocks that people have looked at are things like pollution exposure, say from automobile exhaust or from contaminated drinking water, things like nutritional deficits, from things even like famines that affect what people eat during pregnancy, things like maternal stress. These are all things that have been shown to have an effect on the developing fetus. Not only that, since the time that you spend in utero is short relative to the rest of your life, it's only 9 months, but the effects that people find of some of these shocks are quite large. They suggest that investing in people during pregnancy could be a really cost-effective way to improve their lives by preventing the impact of some of these shocks. Another interesting thing about thinking about fetal origins is that a lot of this research basically shows that both nature and nurture matter. So you hear a lot, even in popular conversation, people talking about, well, is it nature or is it nurture? Usually what they mean by that is something like, well, is something genetic? And if it's genetic, they think, oh, well, that means you can't change it. You're born with the genes that you have. Well, that is true, but you're also born with what's called the epigenome, which literally means above the genome, which you could think of as kind of like a series of on-off switches for your genetic material. When you're, in order for something to actually happen to you, your gene has to be expressed, and the epigenome determines whether it's expressed or not. So one idea is that a lot of the things that happen in utero affect whether these switches get turned on and off, which then has an impact. Okay? So the short version of that is that both nature and nurture matter, because what matters is these interactions between what you're born with in terms of your genetic material and what happened to you in order to set your epigenome in various ways. Oops, sorry. Yeah, so I want to show one example of that. This is graphing data from California birth certificates, where it's showing the relationship between a mother's birth weight and her child's birth weight. This is in grams. So an average birth weight is something like 3,500 grams. Low birth weight is something like 2,500 grams, which would be about 5.5 pounds. Okay? So along the bottom axis here is the mom's birth weight. And then these are the average birth weights of kids whose moms have these birth weights. Okay? So what you can see is the line slopes up. So that basically says if your mom was bigger at her birth, then you're likely to be bigger. But you can also see that there's 2 lines here. And so that's saying whatever your mom's birth weight was, suppose your mom was low birth weight, 2,000 grams. If your mom lives in a poor place, your birth weight is going to be less than if your mom is living in a rich place. Okay, so the extent to which that physical characteristic is getting transmitted from one generation to the other is depending on the environment, in the sense that people who are living in richer places and have more resources are less likely to transmit that negative thing, low birth weight, to their child. Okay. So the next part of this talk is going to be kind of an extended example of how we can change people's health through different kinds of interventions. And the intervention that I'm going to talk about is the Medicaid program, which is the main health insurance program for low-income and actually a lot of middle-income women and children. Okay? So I'm going to talk about expansions of the Medicaid program that happened in the 80s and 90s. This has nothing to do with the ACA or the Affordable Care Act or those Medicaid expansions. Those Medicaid expansions, which happened starting in 2014 in some states but not in others, were mostly to low-income adults. And the reason why they were mostly to low-income adults is because the kids were already covered. The kids had been covered in the 90s. So that's what I'm going to be talking about. Okay, so Medicaid is a really big program. This plot is showing basically how much money in billions of dollars was spent in 1990, 2002, and 2015 on 3 large social programs. The Earned Income Tax Credit is a refundable tax credit that's the main type of cash welfare program that we have in this country now. If you file your taxes, you will see that there's a little box that you could fill out if you were eligible for the Earned Income Tax Credit. And if your income is below a certain level, you get money back, right? You also see, if you could look around, there's all these H&R Block things that will say, instant cash back. Well, that's because you go there, they'll help you fill out your tax, you'll get the cash back electronically, the Earned Income Tax Credit, and then they'll just take their fee out of your credit, right? So that's why they have that business model. So there's the Earned Income Tax Credit, which is quite big, at more than $60 billion. There's SNAP, which is what used to be called the food stamp program. That's also pretty big, at almost $40 billion. And both of those things are totally dwarfed by the Medicaid program. Okay? Medicaid covers other groups as well. So here I've tried to focus just on low-income women and children, and it's still $140 billion. So it's a lot of money. And it's important to say, well, what are we getting for the money that we're spending on this program? Okay. So showing you how big this expansion was, one of the groups that gained coverage were pregnant women. In 1979, about 12% of all 15 to 44-year-old women would be eligible for Medicaid if they got pregnant. Okay, so only about a tenth. By 1993, more than 40% of people would be eligible for Medicaid if they got pregnant. Okay? And today, between 40 and 50% of births are paid for by the Medicaid program. So it's a really big program in terms of covering pregnant women. Okay? Now, this happened on a kind of state-by-state basis, and some states were much more generous than others to begin with. So you have basically different changes in the fraction of pregnant women that were covered in different states, which is what this map is trying to show. So if you look at a place like Texas, Texas was not generous with their Medicaid program. And so they were eventually forced by the federal government to pay a lot more money and cover a lot more people under Medicaid. So they got a big expansion in Medicaid. Other places, like Oregon, was historically pretty generous, so they didn't have to change their Medicaid program very much. Okay, so you have these different changes, and that's what people have used to try and say, well, what was the effect of having a big change relative to a small change on various types of outcomes? So some of the outcomes that showed an immediate effect, which I looked at in some of my early work, were things like whether people were getting prenatal care or not. So if you looked at poor women who gained Medicaid coverage, they were 50% less likely to delay getting prenatal care past the first trimester. Okay, so a lot more access to medical care when people get health insurance. And then that also had an impact on infant mortality. So we saw an 8.5% decline in infant mortality associated with getting Medicaid coverage. Okay? And part of that is because people literally were getting access to care. So they, your baby, when you had Medicaid coverage, would get into the NICU when they wouldn't get into the NICU, that's a neonatal intensive care unit, before. Okay? So giving people access to medical care did have an immediate effect on their health. One thing that's really cool about this particular kind of social experiment is that since it happened a long time ago, we can follow those people whose mothers were covered and say, what's happening to them today? Okay, so those children who were born in 1990 to 2000 are now your age or a little bit older, 19 to 29. Okay? So we can look at those cohorts of people who gained coverage and say, how are they different than the cohorts that came just before them who didn't have coverage? And if you do that, you see a lot of positive effects. Okay, so looking first just at the blue bars on this graph, what I'm showing here is that for all of the affected people, they had a reduction in hospital visits per 1,000, and they had a reduction in the number of chronic conditions that they had. Okay, now, these things were more impactful for poorer people than for richer people, right? Because most rich people already had health insurance, so if they become sort of eligible, it doesn't really do anything for them. A lot of poor people didn't have health insurance, so it had a bigger impact on them. That's what I'm trying to show here in the orange bars, where you see a bigger fall in the number of chronic conditions, a bigger fall in the number of hospital visits, but then you also see effects on some other outcomes, such as income. So you see about a 20% increase in income, an increase in the probability that somebody ever attended college, an decrease in the probability that they were on food stamps, so it's like a decrease in welfare use, and also an improvement on the Kessler Mental Health Index, which is an index that goes from 6 to 30 and measures mental distress. Okay, so it's about a 2-point decline in the Kessler Mental Health Index. So I'll come back to that. So these cohorts whose mothers got health care seem to be healthier and doing better on a number of different dimensions. So the pregnant women got health care. There was also a big expansion to children. And this also was phased in at different times in different states and to different age groups. So first it was phased into the youngest children. So here that's shown by this blue line up at the top. Okay, so Medicaid coverage of children went up, children 0 to 3 went up from about 20% to over 50% by the early 2000s. And then, not much was happening at first for teens. And then starting about 1996, they started getting coverage as well. And their coverage went up to over 40%. Okay, so still today, 40 to 50% of kids in most states are covered by the Medicaid program, which is a huge improvement in health insurance coverage. Okay, so what did that do? Well, one way to think about that is to do an international comparison. One comparison that might be particularly salient is between the US and Canada, and that's because they're quite similar in many ways. I'm Canadian, I can vouch for that, although we like to think that we're really different. What kind of things are the same? One thing that's the same that's relevant for health actually is that people drive a lot in both the US and Canada. That's a big source of accidents and also deaths. Another thing is that they have the same kind of medical technology. There isn't really technology that you could get in the US that you couldn't get in Canada. It's very much the same. Lots of the products that people use are similar. Okay. But one really huge difference is that in Canada, they've had public health insurance since the 1970s, whereas in the US, as I've been describing, they had this big expansion for women and kids. Okay? So that's a big difference between them. So we can try and think about what impact that might have. So in order to do that, what we did was in both countries focus on geographical areas, counties, and kind of rank counties from the poorest places to the richest places. And then for each county group, we'd group them so we have about 5% of the population. And then you can do something like, well, let's compare the areas that are the poorest, 5% of counties, to the areas that are the richest, 5% of counties, and see what is happening in terms of something like mortality that everybody thinks is a good health, sort of overall health measure. Okay, so here's for one particular group. This is kids, 0 to 4, girls. A graph of what mortality rates look like. So this is the number of deaths per 1,000 people on the y-axis here. And on this axis, we've just ranked all the counties. Okay, so what does it mean to be at the 0 poverty percentile? It means that this is the rich place. And 100% poverty percentile, this means this is the poorest place. Okay, so we're going from richest to poorest. Okay, so let's take a look at this thin blue line up here first. This is showing mortality rates in the US in 1990, just ranked from the richest to the poorest places. Okay? So you can see there's an upward slope to the line. What does that tell you? More people die in poor places than in rich places per 1,000. Okay? More 0 to 4-year-old children in this case. Okay? So then looking at the thin line compared to the thicker blue line, what that tells you is what was the change between 1990 and 2010. Okay? And what you see is that in every place, mortality declines, right? But the decline is much bigger in the poorest places than in the richest places. Okay? So one way to think about what's going on here is that there's a lot of technological change in medicine, there are safer products, there are better child safety seats, all kinds of things that can affect death rates. Those reduce death rates everywhere. But one of the things that was driving death rates more in poor places than in richer places was this expansion of public health insurance. Okay? So that's the US, looking at the blue lines. Let's look at the comparison with Canada. That's the red lines here, okay? So this dashed red line, the thinner one, is again for Canada in 1991. Okay? And what this is showing is that, well, the mortality rate in the US for children, girls 0 to 4, was the same in the richest places, pretty much, in Canada and the US. But in the poorest places, mortality was way lower in Canada than in the US in 1990. Okay? Now, again, we can say, well, what happened over the period 1990 to 2011? Okay? And again, mortality fell in Canada for all groups, but it falls in a parallel way. Right? So it falls just as much for the poor people and the rich people. Okay? And so the overall net effect of all of this is that in the US, mortality rates for children became much more similar to mortality rates for Canadian children. Okay? So we give them health insurance, we compare them to a place where they already have health insurance, and what we see is that the death rates become much more similar. Okay, so that's what's happening for this one age group. We can do this for every age group, and of course we want to do this for males as well as females. And just sort of showing you a sampling of what that looks like, you could get a figure that looks like this. So here's the plot we were just looking at, the 0 to 4-year-old females. This is the same thing for 0 to 4-year-old males. Looks pretty much the same. Okay? Now, let's look at what's happening with middle-aged people. Okay? So middle-aged people were not getting a Medicaid expansion until the Affordable Care Act. There's a lot of them that don't have health insurance. There's a lot of discussion about things not going so well for a lot of middle-aged, middle-class people. Okay? So for women, right, we see absolutely no improvement in mortality in the US. Okay? In Canada, there is an improvement in mortality. It's actually a little bit bigger in the poorer places than in the richer places than in the poorer places. Okay? But this gap that opens up between Canada and the US is gigantic, right, in the poorest places. Okay? For males, you see a similar sort of figure. The death rates for males are everywhere above what they are in Canada, in both the rich places and in the poor places. And then for the age 60 to 64-year-old people, it's a similar sort of story. Here you have more of a parallel shift in mortality in the US. But again, if you look at the end of the day, in 2010, 2011, there's still a huge gap in poor places between mortality in Canada and the US. So the only group where you saw convergence is the group that got health insurance, which was kids. Okay, so what I've been trying to argue is that giving people health insurance made them healthier, made them live longer. But since we're talking about human capital investment and getting a return on the investment, maybe people want to know, did they actually earn more money if they're healthier? And it's possible that that might not be the case. So if you have a bunch of people who are kind of sick and you save their lives, maybe they still won't be able to work or earn a lot of money. Okay? So looking at administrative data in the way that we've been doing allows us to assess these effects by looking at these cohorts and seeing how they're doing now. Okay, so what this figure is trying to show is those effects on earnings. And the way that this is being done is by looking at tax data. So I don't know if any of you have read about some of Raj Chetty's work using US income tax data to track what's going on with income inequality. But you can use that tax data and say, okay, let's set what people are paying in terms of taxes to 0 at age 19, and then look at how it changes as they get older as a function of how many years of Medicaid eligibility they gained because of these changes in the laws. Okay? And so what this is saying is for people who are in the poorest families, they gain about $1,800 in terms of, they're paying $1,800 more in taxes by age 28 for each year of Medicaid eligibility that they received. Okay? And then the effects are lower for people in families with 200 to 500% of poverty, and they're the smallest for the richest families. Okay? So it may surprise you to say, well, why should there be any effect for people in the richest families of having a Medicaid expansion? And so one thing to think about is the extent to which giving a whole bunch of people insurance changes the whole system, right? Because now a child who shows up in the ER, the doctors know that they're going to get paid, right? All the poor people have Medicaid. Rich people already have health insurance. So I don't have to worry about uncompensated care, right? And so the protocols change. You see the services change, more hospitals adopting services like having a neonatal intensive care unit to begin with when you see these big changes in insurance coverage. Okay, so I also want to argue that some of this positive effect that we're seeing on earnings could reflect better mental health. There are many reasons why I think this, so I'll just try and go through some of them. But I'll tell you a little bit about mental health and the relationship with earnings and other measures of well-being. A lot of mental health problems are first diagnosed in adulthood, but have roots in childhood. Also, these mental health problems, as I'll show you in a minute, are very common. And they affect a lot of traits or skills that we think of as being necessary to be successful in the labor market. So, for example, things like focus. If I have ADHD, sort of the definition of ADHD is that I have difficulty with focus. Internal motivation. If I'm very depressed and I don't want to get out of bed, I'm having a lot of trouble with my internal motivation. Stress tolerance. If I am anxious and I have panic attacks, then I'm not, doing a good job dealing with stress. And, ability to get along with others. A lot of conduct disorders and so on might impair that, or ability to manage one's emotions. Okay, so you can sort of map a lot of mental health concepts directly into things that we think people need to be successful. As I was saying, these things are kind of prevalent. This chart here is graphing data from something called the General Social Survey, which is a large-scale survey that's done every year in the United States, covers about 100,000 people. And so since 2002, they've been asking questions of people to rate their own mental health. So the question that they ask is printed down here at the bottom. Now, thinking about your mental health, which includes stress, depression, and problems with emotion, for how many days during the past 30 days was your mental health not good? Okay? So the number of people who say they had any days is pretty high. Like about half of people will tell you, in the past 30 days, I had at least one day where my mental health was not good. Okay? But what I think is really remarkable is the number of people who are reporting very high numbers of days. So if you look at people who are reporting 10 days or more of mental health not being good, that's about 15% of the population. And this is people who are working. This is questions that were asked to employed people. Okay? So this is something that's causing, by self-reports anyway, a lot of impairment. And maybe you're skeptical about self-reports. So another way to look at that would be to look at actual healthcare costs. So if you have a mental health crisis in the United States, you're usually advised to go to your nearest emergency room. Okay, so if you phoned a psychiatrist's number and you got their answering machine, it would say to you, if you're having a mental health crisis, go to the nearest ER or phone 911. Okay? So a lot of people with mental health problems show up in emergency rooms. And this chart is just sort of quantifying that. So this is using data for 6 states where you have all of the visits to the ER, all of the visits to the hospital for those 6 states. States regulate hospitals, and one way they do that is by having hospitals, every time somebody shows up, submit a record. So if you look at those records, you have the universe of all visits. There's about 380 visits per 1,000 people to the ER every year. And out of those, about 13% have some sort of mental health indication. About 3% of those are substance abuse, but about 5% are a mood disorder, like depression, and another 5% are anxiety. Okay, so these are people who are actually showing up, generating healthcare costs because they're having a mental health issue. Okay, so I also mentioned that mental health problems tend to begin quite early in childhood. This figure is showing some results from work that we did using data from the US and also data from Canada that was similar. This is from a survey called the National Survey of Youth, where they ask about various behavior problems, and then you can use the behavior problems to come up with scales about mental health conditions. So what we're doing here is we're saying, okay, if the child had a mental health condition at age 6 or 7, and then we follow them up into middle school, how are they doing in middle school? Okay? And what this is showing you is they're not doing so well. Okay? So there's 4 bars. The blue and the orange are looking at whether they had any mental health condition that's diagnosed at an early age for the US in blue, and in orange, Canada. And then we also zero in on ADHD because that's one of the most common things that's diagnosed in really young children. So what this is showing you is that for these kids, if they were diagnosed at an early age with a mental health condition or ADHD, they're more likely to have repeated a grade. They have worse math scores on a standardized test. They have worse reading scores on a standardized test. That one's just available for the US, not for Canada. And in the US, they're also more likely to be in a special education track. Okay? And the main problem with being in a special education track is that it can be very hard to get out of the special education track again once you're there. Okay, so these things are being diagnosed young. They're having a negative impact on things that we think are going to be important for the children's future. Okay. And then these conditions persist then into adulthood. So in a different study, we were using administrative data from Canada to try and look at the impact of mental health conditions at different ages on people's outcomes. Okay, so one very nice thing about having a national health insurance program is that they have good records, so you actually have a record for every single time somebody went to the doctor. Okay, so we're using those records, and then we're matching them to education records from the high school system. People have to write exams on different topics, so we get those exam grades. And then we also link them to the social welfare agency's data on who's using welfare after they turn 18. Okay, so those are the outcomes that we can look at. We're looking at the effect of some common mental health conditions, in this case ADHD and conduct disorders, and then we're just trying to see what effect those things seem to be having on future outcomes. Okay, so we have about 50,000 kids, since this is administrative data, and once we do all of that merging together of data sets, what we're going to do is we're going to compare kids who have a condition to their own siblings who don't have the condition. The reason for doing that is to control for different things that might be different across families. And so the idea is that siblings have a lot in common, not only usually the same parents, but whatever the household circumstances are. Okay, so here's a figure that's just graphing the effects that we find for being on welfare after age 18. So the orange line here is whether the child had ADHD or conduct disorder at age 0 to 3, at age 4 to 8, at age 9 to 13, and age 14 to 18. We have the mental health conditions. By way of comparison, we also have kids with asthma, which is another really common thing, and injuries. So asthma and injuries would be the two most common reasons why kids go to the hospital for physical health problems. Okay, so you can see that asthma and injuries don't really seem to matter that much in terms of this outcome, but having ADHD or conduct disorder is predictive of being on welfare later, and it's more predictive sort of the later in life people are being treated. Looking at a sort of positive outcome, whether you took the math course that you need to take to get into college in Manitoba, right? So like in some state systems, you need to take some courses in high school to even be eligible to go to the state college system. This is sort of the same thing. So if you didn't take the math course, you can't go to college. And what you see is that ADHD and conduct disorders predict that kids are going to be less likely to take these math courses that they need. And again, that's going to have a lot more impact on them than either asthma or injuries, so common physical health problems. And then finally, we can look at, well, what if you didn't just have a treatment at one point or another, but you have treatment over multiple periods? Well, that has a really large effect. If you have treatment over multiple periods for ADHD, then kids are much more likely to be, or less likely to be on track in school, which here is measured by whether they were in grade 12 by the time that they were age 17. And again, the effects are much bigger than the effects for asthma or injuries. Okay, so now I'm going to try and tie two threads together. I've talked a lot about prenatal conditions and how those were related to positive future outcomes. Then I'm talking about the importance of mental health. So now I want to talk about evidence linking prenatal conditions to mental health. Okay? And actually, there's quite a bit of evidence that there are relationships there. So one of the most famous series of studies has to do with what was called the Dutch hunger winter, which was when the Nazis blockaded some of the cities in the Netherlands and people starved. Okay, so it happened over a very particular period of time at the end of 1945, and then there was liberation. So if you look at calories per day, they go way down, deaths start going way up, and then after liberation, calories go back up again. Okay, so you have this very sort of short, sharp shock to some people, and you have babies who are in utero during that period. And if you follow them into adulthood, you find that they're more likely than babies born just before or after in similar circumstances to have schizophrenia. Another study like that looked at the Six-Day War in Israel and found that people who are subject to that stress, their children were more likely to have schizophrenia. Okay. Schizophrenia obviously is a very serious illness. It does not affect that many people. So it's interesting to look at other mental health conditions and ask, well, are those also related to fetal conditions in some way? Okay. So one study looking at that is using data from Denmark on identical twins. And again, in a place like Scandinavia, it's much easier to get for researchers to get access to people's health records, and they're all part of the same national system. So they're looking at every identical twin in the entire country over some 10-year period. And even in identical twins, what you'll see is that they have different birth weights depending on sort of luck of the draw in terms of who got the good spot in utero. Okay? So what they show is that when you compare these identical twins, the heavier birth weight twin is less likely to have ADHD than the one who's lower birth weight. Okay? So that's some evidence that something like ADHD can be affected by conditions in utero. And then a really compelling study using Swedish data, also a situation where they have the data for everybody in the country over a long period of time, tries to look at the effect of maternal stress during pregnancy on the child's future mental health outcomes. And the way that they do that is by saying, as a stressor, we're going to look at people who had a death in the family when the mother was pregnant. Okay? But that's not a random thing. You know, some people, unfortunately, are more likely to suffer losses than others. So you have to have a good comparison group. And the comparison group that they use is people who had a death in the family just after the birth. Okay? And when you do that comparison, what they find is that having your mother be subjected to this emotional shock increased the probability that the child was later using an ADHD drug by 25%, and then it also increased the probability that when these children grew up to be adults, that they were using drugs for depression or anxiety by a significant amount. Okay? So it is possible to affect people's future outcomes through these things that happen during pregnancy, and one of the channels for that may be by affecting their future mental health. Okay. So that's really depressing, right? So the question then is, well, can we do something about it? And fortunately, the answer to that is yes. I've already been talking about something we did do about that, which was expanding health insurance to millions of pregnant women and children. That had positive effects. There's some other kinds of programs that we have that also have been shown to have positive effects. One of them is called the Supplemental Nutrition Program for Women, Infants, and Children. Depending, what neighborhood you go into, if you go into a supermarket, you may see stickers on the shelves that say, this peanut butter is the WIC peanut butter. So people get vouchers that they can use to buy different kinds of nutritious food, and it's aimed at pregnant women and young children. And so we look at WIC participation in South Carolina, and then we ask if your mother was using WIC, what's the effect on your mental health measured at age 6 to 11? And what we see is that we get a reduction in the probability that the children have any mental health condition. That's in yellow. And there's also a reduction in the probability that they have ADHD, which is shown in blue. Okay, so I'm trying to argue that access to these programs is actually making children's mental health better, but probably the only thing that you've read in the news for the last 5 years is about how everybody's mental health is getting worse, right? And then maybe it's smartphones, or maybe it's this, or maybe it's that, right? So why do we keep reading about how things are getting worse if they're actually getting better or should be getting better? Okay? So I'm going to argue that one of the things that's happened is that diagnostic standards have changed a lot. The number of people being screened has changed a lot. And if you do more screening, you find more cases. And that may actually be a good thing and not a bad thing. Okay, so one interesting figure, again, focusing on the ADHD example, what I'm trying to show here is, first of all, so this is data from something called the Medical Expenditure Survey that asks people about the kinds of drugs that they're taking or people in their family are taking. And you see there's an increase in the fraction of kids taking ADHD drugs over time, which is given by this blue line. But almost all of that seems to be coming from the Medicaid population, which is this red line. And if you look at people with private health insurance, it's actually flat. Okay, so that's kind of peculiar. Why should it be that all the increase in medication for ADHD is coming from the Medicaid side of the thing? So what's changing with Medicaid? One of the things that changed with Medicaid is the way that providers get reimbursed. So they used to all get reimbursed on what was called a fee-for-service model, right? So somebody walks in, they get a service, the provider submits a bill, they get paid for whatever they did. Okay? Increasingly, people are now being compensated in a managed care organization. So what that means is that the doctor gets a payment that says, okay, you get paid this much. Sorry, running out of time. You get paid this much for treating this person, and that's supposed to include everything. So you would think that would give doctors an incentive to do less instead of doing more, right? And so state Medicaid programs, being aware of that, said, okay, so we'll pay you more if the person is sicker, because we don't want you to skimp on care for sick people. Okay? So now doctors are going to get paid more if the child has a chronic condition, right? So they have an economic incentive to screen more for chronic conditions because they're going to get paid more per child, right? Also, they're going to get punished if the managed care organization isn't able to prove that they're delivering all these preventive services and screenings to children. Okay? And it's much easier for the government to keep track of like one managed care company than to keep track of every individual physician and make sure that they're doing all this screening. Okay? So what you see, since I'm running out of time, I won't go into the data very much. This is also in South Carolina. But what you see is that if you look at the kids in the program before the change to managed care compared to after, you get a big increase in well-child screenings. And the increase in ADHD exactly tracks the increase in screenings. Also, if you look at the same child before and after getting moved into managed care, you see increases in well-child screenings, developmental screenings, vaccinations. I mean, they're all supposed to be getting vaccinated, right? But they're not all getting vaccinated, so that's why you can get an increase in vaccinations, and even an increase in sick visits. And then if you look at diagnoses, you do see increases in diagnoses for mental health conditions, ADHD and depression here. And maybe you would worry about that. But on the other hand, you are also seeing increases in diagnoses of things like asthma, even mild infections, ear, nose, and throat, and so on. Okay? So this is just an example where more kids get access to care, more kids get screened, and then you find more things that are wrong with them. Okay? And like I say, that could be a good thing and not a bad thing. Okay. So we've been talking about prevention. We've talked a little bit about diagnosis. Of course, that sort of the next thing would be treatment. The US is a good laboratory for looking at these kinds of things because we have so much variation in the kinds of treatment that are going on across areas. There's a lot of variation that you can use to try and see what is the effect. Okay, so just as something to think about, here's a figure which is showing for each county in the United States the number of antidepressant prescriptions per 1,000 10 to 19-year-olds. Okay? So the dark red here is 967 or more prescriptions per 1,000. This is 1 month prescriptions. So, and then the light color here, the lightest color is 0. Okay? So we have some counties where no kids are getting antidepressants, and then we have some kids where, or some counties where very many people are getting antidepressants. Right? And so that kind of variation could be used for research purposes. It's a little disturbing because we know that there are health risks associated with these drugs. All of them have black box warnings for suicidality up to age 24. So it could make things worse and not better. There's very few drugs that are actually specifically approved for use in children, and so most of these drugs are being prescribed off-label, and we don't really know anything about what the long-run effects of all of this is. Okay, so just to summarize then and conclude, child health, I hope I've convinced you, is a really important form of human capital in the kind of traditional sense that better health has a return. People live healthier lives and earn higher wages. Improvements in physical health, which is what people think of when you say health, are really important, but mental health may be even more important in terms of predicting how somebody's going to do in life. Mental health diagnoses in children are increasing. There are lots of reasons for that. It's not necessarily a bad thing. But we don't really know very much about whether the treatment that we're doing is effective and whether it's going to, in the long term, help people to live better lives. And I want to add one thing, sort of as a postscript to all of this. So I started off with kind of this happy story about how we gave health insurance to millions of people, and it had, great effects on the rest of their lives. Well, we're in the process of unraveling that. So I don't know if anybody saw this story that appeared in the Upshot very recently, talking about how 1 million kids have been thrown off of Medicaid in the past year. Some people have argued, well, that's because unemployment is so low and people are getting jobs. But that does not seem to be the case because most of these people that are getting kicked off are uninsured. So what's going on with that? Well, one of the things that's going on is that a lot of immigrants are now afraid to use any kind of social services because they don't want to be labeled as a public charge and thrown out of the country. So you could have an immigrant parent or a household with one immigrant person in it, American children, and the American children are not getting Medicaid because their family is afraid. Okay, so that's one thing. Another thing is that a lot of states have just sort of taken it upon themselves to change the way that they're administering the program. So this particular story is about a mother in Texas, and Texas changed their computer system and sort of said to everybody who's on Medicaid, okay, you may be eligible for this program, but now you have to re-enroll. And they just sent notices to people and said, if you don't re-enroll within 10 days of this notice, then you're kicked off the program. So this woman who just had a baby didn't notice the notice, had 3 kids. They were all thrown off of Medicaid. She showed up at the hospital with this baby who was really sick and was told, oh, sorry, you don't have any health insurance. Okay, so this is the sort of thing that's happening right now. And one reason why I go around talking about Medicaid and this expansion that happened a long time ago is because I feel like if people don't understand what the programs did and why they're important, then it's much easier to just roll them back. So that's all I have to say, and I'm happy to take questions.